Welcome. We are having a really special talk today from Linda Dimeff on just how important are DBT skills, a brief research walkthrough. And Linda, as you guys may know, has been integrally involved in the research on dialectical behavior therapy for years and years, and very active in skills training herself. And what you may not know is her ability to kind of pull together and distill the science on an area in a really concise way. So what she's done for us, and Linda, I just feel so appreciative, is gone through all of the data that's out there on DBT skills and tried to distill it into a very, practice-friendly, you don't have to be a researcher to understand the implications of the findings. So Linda, thank you so much for doing this for us, and the floor is yours.
Thank you, Kelly, and everyone. Thank you so much for joining. I have to say it's been just a real delight to have a chance and an opportunity to look through the literature in more detail than I've had an opportunity to. So this is since the emergence of Marcia's most recent and super exciting component analysis study. So first I just want to say I've slightly revised the slides. There's not a ton that's new. What is new, you're just going to want to get the more recent copy of the handouts. And fear not if you don't have them, because again, 95% is what you've already received. But I wanted to start with this slide, which is just to say, several years ago in 2009, there was a fairly large undertaking in the UK by the National Institute of Health and Clinical Excellence in the UK. And, what they did was pull together a group of DBT experts really from all over the world to create practice guidelines. And those have really been, pretty instrumental for many BPD researchers going forward. And this is actually just to credit Kin Silk here for distilling a lot of these sort of finer points here. But what they essentially what you see in the NICE report is that if you're looking for what works well for BPD, you're going to be seeing these three basic elements. And what this group of experts, basically found is that the evidence-based therapies for borderline personality disorder, they are structured and coherent. And they include a multidisciplinary team where people are either receiving feedback and or providing feedback, and they're specialists. Now this is important. You've got the link there, so if you want to go to it, it's been updated in 2015. If you haven't been to it, there's just a ton of information there. It's worth going to. But this is important because as we look at the rest of the evidence base for skills training, you can hold it against these standards set by NICE, and you're going to see, I think, a certain emergence of a pattern. So just to say, this is a super exciting time from my perspective in BPD research, because we're learning more and more about what are the active ingredients of this treatment and what seems to really be making a difference. And obviously we're also seeing Linehan and her colleagues move in the direction of really the push toward certification and accreditation of programs. But kind of going back, this is my skills training, my textbook from Marcia's original textbook for DBT. And you'll notice that on oh my gosh, I don't know that I can see it. I think it's page 24. But she talks about study 2. And study 2 was Marcia's first effort to really begin to understand what is the importance of skills training, and is it possible to kind of pull out skills training as a separate mode and actually still get efficacious results. So she asked the question, this is taken right out of her book, if a BPD patient is an individual non-DBT psychotherapy, will treatment effectiveness be improved if DBT skills training is added to therapy? So it's a small study, as you can see. Basically, people are randomly assigned to one of two conditions. They either had the add-on of skills training, or they just did not receive the add-on. And what you can see here, and many of you already know this, but just to say, results from that study, with the exception of the fact that we retained subject in skills training reasonably well over the course of the year, 73%, which is actually quite high. the results suggest that DBT skills training may provide little, if any, to recommend as an additive treatment to ongoing non-DBT psychotherapy. So at that point, Linehan was very clear, and she then does this post hoc analysis where she looks to see, how do these results compare to results from comprehensive DBT. And in fact, there's further support that would suggest that simply doing skills training outside of a context of a comprehensive program doesn't seem to add value. Okay, so this is important because, as you know, Kelly was one of the founders along with Marcia of BTEC. We, for these reasons, had a big emphasis on making sure that DBT was full fidelity when we would train. And that's part of what led to the impetus of certification and accreditation, knowing that a lot of people were calling things DBT that really weren't DBT, and oftentimes that looked like skills training alone. And largely, that's because of this study. All right, so now why do we care? What's at stake? Obviously what's at stake, and this is not insignificant, is, do you offer comprehensive DBT versus a la carte? If you're an organization that has invested heavily, as, certainly at the University of Washington and Portland DBT, we have in developing and sustaining over time comprehensive DBT, it's very hard to compete with people who are just doing a la carte. So there's that. There's how rigorous do we need to be in our training approach? Do we need to be really pushing for that nice standard that Linehan has always adopted of rigorous, highly trained specialists? Or is it enough to simply have a la carte people doing, kind of whatever they want, but then adding in skills training? And ultimately, obviously, the bottom line here is, are we actually going to make a difference in terms of reducing suffering, and not only just reducing suffering, but radically improving the lives of people with BPD and curing, like really where they're not meeting criteria for BPD and they are having as awesome of lives as you are, the problem, or are we prolonging suffering? So this is why this issue of skills training matters so much. All right, so I'm not going to go into great detail, but I do want to just highlight that there's been a number of studies before Linehan's component analysis study. So, one in 2006 by Gratz and Gunderson. This is also an add-on. It's very similar to that study 2 that we just talked about. Small sample, you can see only 22 people. They received 14 weeks of emotion regulation. And it was kind of a hodgepodge, but has much of the flavor of DBT. Kim describes it as ACT and emotion-focused therapy informed, but if you look at the function, there was a great emphasis on people understanding what's the function of self-harm, really helping people understand what their emotions are, how to label emotions, and how to just sit with and experience emotions as opposed to engaging in dysfunctional behavior. As you can see, she has positive results. So this is kind of interesting. This is the first time she's, obviously split out emotion regulation only, and she's getting a different finding from what Linehan found in that study too. And of course she's, okay, so continuing on here. And then we have Nancy Bloom's STEP treatment, also an add-on. This is kind of interesting. A much larger sample, 124 people. For those of you not familiar with STEP, it's a very sort of efficient, skills-based approach that in many ways resembles DBT. She describes it as cognitive behavioral therapy. 2 facilitators are conducting the skills training session, and it's highly structured, and like DBT, there's handouts and homework assignments, et cetera. So interestingly, again, and she compares it to basically add-on. So just like study 2, we've got treatment as usual, adding on steps as a group mode for 20 weeks is the intervention. So what does she find? This is interesting. I mean, she finds that STEPS is superior to TAU, just again to remind everyone, it's treatment as usual, that it's superior in terms of impulsivity, negative affect, mood, global functioning. In fact, one of the big behavioral outcomes here is that emergency department visits go down significantly more than in the TAU group, but actually there's no change in suicide attempts, non-suicidal self-injury or hospitalization. And interestingly as well, even though, you know, generally her dropout rates are you know, actually not bad for a treatment for BPD. The STEPS had a dropout rate that was twice as high as TAU. All right. So now, next study, this was done by Farrell and his colleagues in 2009, and this is based on schema-focused therapy. Again, another add-on. So they've got regular old individual therapy that's occurring, and then they've added on a schema-focused therapy group. 8 weeks, 30 sessions, and you can see again that in comparison to just regular old treatment as usual, you're seeing positive outcomes with the added focus of group, decreasing BPD symptoms, global severity of psychiatric symptoms, improving functioning, and treatment retention. 94% retained over the course of 8 months is actually quite phenomenal. All right, and then finally, Solar and his colleagues, this was a sample of 60, and here what they were doing is really just comparing, you know, is there some benefit to doing skills training versus regular old group therapy in a 3-month trial. And you can see that the group that received DBT had better treatment retention over time and generally better outcomes in these particular areas. This is one of my favorite studies, I have to say. For those of you who were at DBT several years ago, you heard Shelley talk about this data herself. Shelley McMain is one of the really just a terrific BPD researcher in Canada, and has done some of the largest trials to date and really some of the most complex work in the area of DBT research and also just sort of BPD more broadly and more generally. But this was the impetus for this study, as Shelley shared at is that they were trying to understand and figure out a system to more effectively manage people on their wait list. So it's something that all of us struggle with is, you know, what do you do? And there's a fair amount of research that shows that if you are on a wait list, what happens with people on a wait list is they wait. And you don't actually see people kind of stagnate. And you're better doing something than nothing. And this is, in the world of research, one of the reasons why there's been a critique about using wait lists as a control condition. And, you know, Bill Miller and others have said that if you tell people to wait because they're on a wait list, then they'll wait. And so she was trying to figure out, well, how can we deal with our wait list? And it was that gave the impetus to this study. And it really wasn't intended to be anything more, I think, than her team's effort to understand that problem. So she does a beautiful job. Again, it's another randomized controlled trial. It's 20 weeks, regular old standard treatment. What's important about this is that they're also doing, this is being delivered by a team that's providing comprehensive DBT elsewhere. They are all extremely well trained and expert in DBT. And she divides the sample randomly, again, between the DBT group and the wait group. They received 20 weeks plus a 3-month naturalistic follow-up. And then I just think this is, for those of you who are trying to figure out how to deal with your wait list, there's just some ideas about, kind of maybe how to structure this up. So this is what she does. You can see that her groups are 2 hours long. Presumably it's an hour for acquisition, an hour for strengthening. Before people get started, they're doing a 90-minute pre-treatment commitment session. And importantly, medications and other psychosocial treatments are monitored, but they're not controlled. So they're uncontrolled. People are using whatever they use. And importantly, clients are expected to have an outpatient treatment provider, and presumably that's to make sure that should a crisis arise, they're not calling the group leader, they're calling whoever that might be. Oops, uh-oh. Oh no, Linda. Uh-oh. sorry, you guys, my slides are out of order. All right, so here is the results from that study. So, so DBT was, you know, kind of not surprisingly in some ways, but look at the findings, was superior to waitlist on frequency of suicide and non-suicidal self-injury. So this is huge, right? That's a big finding. Anger, BPD symptoms, this is at post-treatment, so apparently it didn't continue for the follow-up period. Depression at post-treatment, but it didn't continue for the follow-up. You see a significant difference between the two conditions on measures that assess mindfulness, emotion regulation, and stress tolerance. And while it wasn't statistically significant, there were, at least in the right direction, improvements on impulsivity, hospitalization, and emergency room visits. All right, so so that's Shelley's study. Now going back, so Shelley's was 2013, so now we're actually going to go a few more years before. And part of the impetus for Shelley's research, in addition to really trying to address the what do we do with people on our waitlist problem, was this study by Andrada, Shireen Rizvi, and Marsh Linehan. So, and many of you are familiar with this research, but what they did was basically pulled together, this is primarily Andrada, they pulled together all of the research that had been done at BRTC to really look at what is, you know, how important are skills. And this is now a very commonly cited study by many people doing DBT research, because you can see from their outcomes what they found when pulling together all of this data and really trying to understand who had the best outcomes. DBT skills as an outcome, DBT group used 3 times more DBT skills at the end of treatment than their controls. So we know that, in fact, if you're in a group, you're actually more likely to use skills than any other control conditions. And again, in Linehan's research, these control conditions are pretty rigorous control conditions. And skills used in the DBT group were maintained 4 months after follow-up. Super important. That would also speak to the importance of skills generalization that occurs during DBT, that people continue to make use of skills after comprehensive DBT has come to an end. And by the way, I should just say, if it's not obvious, this is looking at data from Linehan's research trials where people were receiving comprehensive DBT. So what do we know is that DBT skills use mediated decreases in suicide attempts and depression fully, you see an increase in their capacity to control their anger, and a decrease in non-suicidal self-injury partially. So this is huge. I mean, what this really says is, you know, the take-home of this research is the more skills a person uses the more often, the more likely you can expect a decrease in suicide attempts, depression, anger, at least their capacity to control their anger, and to some extent also non-suicidal self-injury. All right, so this is, I think, the study that many of us have been waiting for, and this is Marsh's component analysis study that was published earlier this year in JAMA. And this is the one where Linehan wanted to, you know, again, the impetus for this study by Marcia and her colleagues was, you know, largely to figure out what is the, you know, important role of skills training. Now, I have to tell you that the findings, and I know some of you know the findings, but for many of us, it was exactly not what we were expecting. So here's the design just at a high level. Again, the objective was to evaluate how important is the skills training mode. The study was just about 100 people, 99 you can see below, 33 people assigned to both conditions. Just in terms of the structure of the treatment itself, it's just standard 1 year of DBT. DBT, that's, you know, the model that you typically see in Linehan's research, followed by 1 year of follow-up. And these are the 3 conditions. So comprehensive, all the bells and whistles, DBT skills training only, kind of, and individual DBT individual therapy. Now, I just want to kind of go into a little bit more discussion of each of the different conditions. So, you know, what you're doing, and I realize some of you know this, but just to say, when you're structuring a study like this, one of the things that you have to make sure you're doing is to control for threats to internal validity. Well, one of the obvious threats that you could immediately see, if this is what your conditions are, is, you know, that perhaps if we end up seeing that comprehensive DBT is superior to these other two conditions, perhaps it's because they had more time, right? They had more meetings, they had more people on their team, and that's the reason why. So it really doesn't actually have to do with the primary research question, which is to evaluate the importance of skills training mode. It's more simply about the amount of time in treatment or the number of treatment modes. There's some other considerations too, but that's kind of in a nutshell why all of these things have to get balanced, and it's important that we're going to talk about this balance when you see the data. So the DBT skills training, so in this case, I know for some of us, we associate DBT-S with DBT for substance abusers. It's not in this case, it's DBT skills training only. So individual therapy, that's IT, was replaced by manualized case management intervention that follows a strengths-based needs assessment model. Like you're helping the client find resources, providing information, you're assisting in problem solving, you're managing suicide crises. All right, and importantly, as we'll talk about later, you're using the LRAMP, which is the Linehan risk and management protocol for suicide. So that's what that is. So the client is getting skills training. All of the therapists in this study are on consultation team. Everyone is using the LRAMP in treating suicide crises to manage the risk. And in this particular condition, because they're not getting individual therapy, they're getting case management, all right? Now over here in the DBTI condition, DBTI is individual psychotherapy only, so this is DBT individual psychotherapy. So here, the therapist, the DBT individual therapist had to focus on patients using skills they already had. So everything is kind of the same in this mode of treatment, except rather than coaching specifically on skills, rather than asking how what did the client go to group, using the language of DBT skills, they're much more broad and global. So, skills, the assumption is that they already have skills. Things are very generic. Therapists suggest suggestions by the clinicians. They're using standard behavioral vocabulary as opposed to DBT-specific vocabulary. Now, to control for the threat of internal validity on this one, notice that they have this thing called an activity-based support group. So this is delivered by that same team of case managers, and what they're doing are things like psychoed, activities, recreational activities, drawing, movies, going to social outings, but no group. Okay, so they're still having opportunities to come together as a group, as a community, but again, not for purposes of skills acquisition or strengthening. So what all these conditions have in common, this is important to know as you contemplate, the implications of this for your own clinics. All DBT therapists are highly experienced DBT practitioners, so all of them have extensive training and supervision by Linehan directly. All right. All therapists are on a consultation team, and all therapists are managing, and this includes the case managers, are using the LRAMP to manage suicide crises. All right, so if you don't already know, I feel like we need a drum roll or something, Kelly, here. So here are the findings, and this, again, this is sort of shocking, and it was not, I can tell you what anyone was expecting, including Linehan, but as she says, all data is good data, and it's good that it is because, it allows us to move forward and hopefully improve DBT and get more parsimonious in what we focus on, and hopefully with the goal of having better outcomes for our clients. Three conditions, all three significantly reduced. So if you look pre to post, suicide attempts, suicidal ideation, and severity, medical severity of non-suicidal self-injury. And all three conditions reduced crisis services due to suicidality, and importantly, reasons for living increased in all three conditions. However, standard DBT, and this is really, this is kind of the big one here. Standard DBT was not superior to DBT skills training only, or DBT individual therapy for any of the suicide-related outcomes. And there were no differences detected between these two conditions. All right, so all three versions were comparably effective at reducing suicidality among individuals at high risk for suicide. That's a direct quote from the paper. So if we look at point number 3, the conditions that included skills training, so this would be comprehensive DBT and DBT skills training, were, however, more effective than the DBTI at reducing non-suicidal self-injury acts and improving mental health outcomes, importantly. And those without skills training were also slower to improvements in depression and anxiety during the treatment year. So again, you know, what we're seeing here is that where the benefit lies is in skills. That was the question that she originally asked. If you lump those two groups together and then you look at, are there improvements that are better than the group without skills? And the facts are on reducing non-suicidal self-injurious acts and improving other mental health outcomes. The answer is yes. All right, so now here's the other thing too that I just kind of want to, this is one of the slides that you don't have that you will have in the new materials if you download them. So what's important, I think, as we analyze this is that if you look at the number of sessions across treatments, because this goes to dose, right? What you're seeing is that, so this is the number of individual sessions by a study therapist, all right? So, you know, check this out. The, not surprisingly, the standard DBT, they had an average of 41 sessions. DBTI, it's a lot less, it's 30. And then in the DBT skills-only condition, they had 19 individual sessions. Okay, so that's important, right? Because this is like 19 meetings with a case manager, all right, doing whatever. But it certainly wasn't an inert condition. The other here is the number of groups that clients attended by a skills a study therapist. So not surprisingly, in comprehensive, a lot of people went to group, 32. The standard number of attendance at group was 32. In the individual only, the standard was 6, so it doesn't look like the activity group was like awesomely effective or liked, maybe is how I would interpret that. And then over here in skills training, on average, they went to 23 groups. So, and then if you add the total number of hours of treatment, you get that, and again, this goes to treatment dose, 52, 49, 50. So really not significant difference between the hours that they received. If we look at dropout rates, another, you know, big important outcome variable, clearly the best at retaining people is at 24% is comprehensive DBT. And, you know, as we think through what is one of the functions of individual psychotherapy, it's motivating the client to do what they need to do, right, including staying engaged in the treatment. So that combination of individual plus all the other modes, including skills, keeps people in. A much higher rate on DBT for just getting the individual, and still, you know, lower than the individual therapy only, but certainly higher than comprehensive is the skills training group. Look at some other advantages of standard DBT compared to the other conditions. So this is standard DBT compared to just doing individual therapy, the individual therapy component. Again, we just saw this. There's a significant difference in treatment retention and reduction of non-suicidal self-injury frequency, improving mental health outcomes, and reducing emergency department visits and hospitalization. And you see that after treatment. And then this is kind of interesting. While it's not statistically significant, Linehan makes the point that clinically it does seem to be important that standard comprehensive DBT appears to be actually more robust in the follow-up year. So this is, you know, again, it was not statistically significant, and it could be that it's a power issue. We don't really know. But certainly that what you see in those who receive comprehensive DBT is that suicide attempts, emergency department visits, hospitalizations were 2 to 2.4 times lower in comprehensive than the other most robust condition, which is DBT skills training only. All right. So I'm almost done, you guys, and you can ask your questions. You know, what's the takeaway? And, you know, this would be actually a really interesting conversation, because as we look at, you know, the research as a whole, I mean, I think unequivocally what we can say is that skills training matters a lot. And the other thing that I think we can say is that it's not just the skills alone. And I think this is important, because when we get out there and we're either training other people or we're consulting to other organizations about how are they going to set up their DBT program, you know, you are going to get the biggest bang for your buck if you have, for sure, the structure of a comprehensive program, even if people are only receiving clients in that program, and this is the McMain research, skills training, right? But where still the clinicians are in consultation team, and where it is a specialty clinic providing treatment to a specialized patient population using a specialized structured coherent treatment, and also where there is a suicide protocol, you know, that is a consistent coherent suicide crisis management protocol. Again, in the case of Linehan's research, it's the LRAMP, but, you know, it may be that people are using CAMS. What matters is that it's evidence-based, it's coherent, and it's used consistently within the structure of the organization. Now, the other thing that I just want to say for myself, and I feel so strongly about this, and now I'm just going to, for a moment, I mean, I'm going to put on my Portland DBT Institute hat from a liability management perspective, and also just from a straight research perspective. You know, not in a million years would I think we have enough data to support going after replacing skills training, replacing comprehensive DBT with skills training. So Linehan's study, despite, you know, the McMain study, there's a big database that exists with now at this point 18 randomized controlled trials showing that comprehensive DBT is efficacious. So to throw that out, particularly when this most recent component analysis study with relatively small N has not been replicated, I think is really a mistake. And again, we just have to remember that is a study that was like gold standard. It doesn't get really any better than a study like that being done by Linehan, the treatment developer at the University of Washington, by a highly experienced group of people who are constantly being supervised and trained by Linehan herself. So, you know, I think that what it does say is that, you know, we need to make sure that we learn these skills, that we find absolutely the most effective way of teaching these skills, that we are coaching unrelentingly on skills, that we all, you know, if our games aren't already at the Kobe Bryant, you know, level of, you know, game of doing DBT, that we get them there because of the importance that clearly they're playing as an important part of this treatment. And again, if we look at the other research that even outside of the DBT literature, you know, clearly clients who learn skills show, for the most part, improvements. I mean, that's the consistent finding, isn't it? All right, so Kelly, at this point, I'm going to turn it over to you just to say that was 34 minutes. Kelly wasn't sure I could do it.
That's true. No, it was a whirlwind, and I imagine that may leave people with some questions. And if you would, type those into the text chat area and send them to me, Kelly Koerner, or the host, and that'll let me add them to the queue. But I do have quite a few here, Linda, for you, and they range around. So a couple of easy, just straightforward ones. Do you know, is Shelley's McMain study published? I did a quick Google and didn't see it.
No, it's not yet. And I will happily shoot Shelley McMain an email after this and ask her if it's in what the status is. It's such important research. Okay. And maybe, you know, if I can just kind of add, I mean, we've taken her model at Portland DBT Institute and, you know, done some slight variations and tweaks of it. We'd be happy to, you know, kind of share what we've done there. But, you know, it's, and, you know, and the data has been presented. It'll be, I think, presented again, hopefully at a poster session this year. But, you know, our sense of it is that it is actually a very exquisitely effective from a way of managing the wait list. And if done right, you know, people get to the end of, you know, their treatment using that approach. And sometimes we'll say, you know, I don't need any more. You know, that it's done the trick. So, you know, just sort of thinking about like where, you know, McMain's, where that goes, it may be that it helps us also think about how to, there's an approach for triaging. I was somewhere not too long ago where they told me they have literally a 6-month wait list for their people receiving. So again, it's a great alternative.
Yeah, that's fantastic. Linda, then just now some clarifying questions to help us understand some of the data. So in these ones where they had DBT skills training, did they have 2 skills trainers, do you know? Was it kind of that standard in that way, or just one?
So the ones, so McMain and Linehan, they had 2. And I think actually if we were to go back, the STEP, they have 2. I'm not sure about Kim Gratz's research. But if I can just comment again, and this is just, again, with like my own institute director hat on, I mean, when you don't have 2 skills trainers in that room, I mean, there's a reason why Linehan wanted to have 2 therapists in the room. And it's to manage, you know, when you've got one person who has a suicide crisis or who's engaging in really extreme, egregious behavior, someone has to be able to, you know, deal with it, manage it, and someone has to keep the group going so it doesn't get, I mean, so everyone else doesn't lose the most important part of their therapy or one of the most important parts of their treatment.
Great. So then, Linda, also just understanding the comprehensive conditions in Linehan's component analysis, that included skills coaching, consultation team, skills group, and individual, correct?
That's correct. It's just okay, regular old comprehensive DBT. And then the only difference is, right? Sorry?
No, go ahead.
Go ahead. I was just going to say the only difference is that, you know, in the individual group, right, they're not talking about skills, so the client can still call and receive assistance, but they're not coaching on any skills. And in the skills training group, they have no individual therapist. You know, crisis calls are taken by a case manager who's doing, you know, the all-ramp.
Okay. Okay, fantastic. That was another question is, if you are, this is a little expanding from the data, but back to your ideas of how you guys are doing things at Portland DBT, especially with a wait list type group how do you handle skills coaching in that type of a situation where, you're not doing maybe comprehensive, or I don't know, I guess this question is more about how do you handle skills coaching if you were doing, or how was it handled maybe in the condition with the case manager?
Actually, I'd have to go back actually and look, and I will go back, and I will, I don't want to take your time while I'm digging through to see, what they actually did. I'm not sure. But I mean, my guess is that there wasn't skills coaching by the case manager, because that would be part of what you get in individual therapy. But I will confirm that, everyone, and I'll include a slide. So the other question is, how do you do skills coaching, like if you're doing like a McMain version? Is that your question, Kelly?
Yeah, exactly.
Yeah, I mean, I think like that's where you have to get creative. I mean, the whole thing is that if, the whole thing for all of us who are, trying to solve this problem here is that the moment a person is, you're taking on the responsibility for that client clinically, like where you are their 911, you're assuming the clinical burden, then, you're in a different level of responsibility and risk. So you're no longer able, like, then you're out of the effective, efficient way of managing your, your wait list, right? So like personally, I think if your goal is to have an approach in your clinic that helps you with your wait list, you really can't do phone coaching. What you could do is that you could figure out within the client's natural, ecosystem or whatever, their natural life, who can they rely on for additional assistance. So you might, point them in those directions. The other thing that we did at Portland DBT that's a little different from Shelley is, but it's, I mean, it's just a little additional thing, is that we added a skills coaching session every other week. So and the reason for that, and basically the person meets with either a pharmacotherapist or a skills coach. So every other week, someone for 30 minutes is laying eyes on that client outside a group. And if they're not doing individual therapy, they're coaching on skills, and they're really helping the client, further refine their skills use. And again, we're very careful about this because we don't want to do anything that increases our liability. So again, there's someone outside, just as there was in the McMain study, who's assuming clinical responsibility. It could be a psychiatrist, it could be a nurse practitioner, it could be a case manager, but it's not you.
That makes a lot of sense. And then again, it looked like one of the findings was that, there's some better retention in treatment. And one of the questions that came through was, what's our benchmark? What would you say is the average acceptable dropout rate if you're looking at a group treatment? Do you know?
Well, those are two different questions, right? I mean, what's acceptable, right? And what, and what's the average? Yeah. So, So, I mean, I think like if you look, at the whole, and you were to average everything together, you're probably looking around 30%. If you look at, stage 1 BPD research. Now, okay, I just want to say that when we did that study, some of you know this, of DBT for substance abusers compared to comprehensive validation only, we had 100% treatment retention. So, that to me is what the gold standard should be. And it's really interesting. Like, why is it that in that condition, comprehensive validation, where you're doing a fair amount of activating one's own wisdom, that you end up with 100% in people who are as severe as they come. And that's a very challenging population.
Yeah, so you're saying, look, take it as a gold standard for 100%, but on average, it's somewhere around 30% dropout. Yeah.
Yep. And some less, right? Some more.
Some less. Okay, great. And then there were a couple of questions around diary cards. So if you were doing a skill.
Uh-oh, Kelly. Couldn't hear you. I'm still not hearing you. Kelly?
Hey, Linda, it's Katie. It looks like Kelly's audio actually dropped off, so I assume she will be back in a minute. But if you want to just chat with people in the meantime.
Sure. Well, I'll try to intuit. Thank you, Katie. I appreciate that. What Kelly was going to ask. So if we contemplate, you know, in light of this data, like what changes would, you know, we make to the diary card? I don't know. I mean, I would be interested in a discussion about that actually, but I mean, I think for sure, you know, Linehan's diary card that includes all the skills, what we, you know, call the backside of the diary card is what you would, you know, certainly want to include and really pay attention to, like really pay attention to. Like, I don't know.
Thanks, Linda. Yeah, no, that was a pretty good guess. I think it dropped mid-sentence, and what I was wondering about was, do they do the front side? Do you know if any of the research they also completed the front side, or was it just the back? Do you know?
I'm pretty sure it's just the back, but because like, so you know, for Linehan's study, I'll verify that, but I'm quite sure, and I'm pretty sure for McMain, I'll ask her as well. You know, the moment you get the front side of the diary card, what do you do with it? So, I mean, again, it's a liability management issue. Like I can tell you, we're not doing the front part of the diary card.
Mm-hmm. In your prior,
in the context when we're doing our waiting well.
Before. Got it. Yeah, waiting well group. Yeah, that totally makes sense. And then another kind of nitty-gritty question. The new diary card in Linehan's new manual no longer lists the individual emotions. It just has emotion, misery, and then emotions, you know, and then you write in which emotions. Do you know anything about the rationale for that change? Or?
You know, I don't know for Marcia, but I could guess pretty well. I mean, I think it's probably because, you know, she was creating a generic diary card that would be used for a lot of different populations. And for some people, the primary problem maybe anger. I'm hoping you're not hearing my dog bark too much. And for other clients, you know, the primary problem may be, you know, shame. So I'm guessing that's why.
Okay, to add flexibility to really make it so it worked for everybody. That's great. And then do you have a couple of questions about generalizing from the findings you shared? Do you have anything you would say about how this data should influence those of us working with skills in shorter term, say inpatient or briefer types of treatment settings?
Yeah, I mean, I think the thing is, I have this image. Some of you know Cedar Coons, who's another DBT expert who did the first, you know, trial. Second trial, the first one after Marcia published her 1993 study. So Cedar always talks about, like, you know, the job of the skills trainer is to mush. And she makes a whole gesture, you know, like there you are at the Iditarod at the starting line, and you're just like mushing. And I think the thing is, you've got to think, you know, you've got to be thinking of your briefer stays as, I don't mean this in an offensive way, but as like boot camp, you know, and not that there's not kindness and compassion. I mean, you need all of that and ways to cultivate motivation, and you've got to make it fun, otherwise they won't do it. But there has to be just a, from every single person who is touching that person. So, and then maybe this is our last question, Kelly, but just before I hand it over to you, so we're doing, we have EPI has a contract with the state of New York for the juvenile justice, all the facilities that are part of juvenile justice in the state of New York. And so we go into the facilities, and, you know, the thing is, what we're saying and what we're doing is every single person that touches a kid, like every single person that kid has access to, is able to teach and strengthen a skill and get the kid to practice, you know, from the horticulture person, you know, the person who's, you know, passing out the meds, you know, the nurse who's doing the med duty, you know, the guy who does rec, the teachers in the classroom, that there is they are surrounded by skills. And so that it's just, by the time they leave, it's just so ingrained. Everyone's speaking the language. You look around, just like in a 12-step meeting, you can see posters, you know, that remind you of the skills and other cues. And that you're reaching to their whoever they're going back to, whether it's a spouse or their family or a roommate or, you know, whoever they have, and you're making sure that you're passing it down, you're helping the transfer downstream. So going back to the state of New York for a moment, you know, we're doing a lot to reach out to the social workers who are going to be working with the families. The families, when the kids are still in facility, you know, we're encouraging every moment that a family member is engaged with a kid, the family member saying, teach me a skill. You know, what skill did you learn this week? You know, so again, they're learning it, and they're also learning the importance of these skills. So I think it was probably a very long-winded answer. I apologize, but anyway, something like that.
No, it brings home what you were saying, which is skills are important. The more you get people learning them and actually doing them, the more you can expect that to impact outcome. And then I think, you know, just to bring home one other one, this is the part where I can't tell. I wish there was a way to, like, really remove the part of your brain that can have any bias. But if you really look at those data and, you know, from a liability point, you're saying, look, do comprehensive. That's where the most data is. That's where you should sort of take your stand. But there's a part of me that says, it sure does look like a very strong skills training plus adequate, you know, other components. It's looking pretty promising. You know, a treatment that where you could really train people in good suicide risk management, make sure they're supported. Would you, I know it's not where the data are exactly right now, but if you were going to, could I get you out to take a little risk? Okay. Is it?
Yeah, no. I mean, I think, no, okay. I think it's a both and. I mean, honestly, if my daughter had BPD, I would be looking for a comprehensive treatment, you know, and I would be making sure that, I mean, knock on wood, I don't think she does, I don't think she will, but, you know, the point is that, you know, the gold standard is still comprehensive. It's just more like, what do we do along the way while we're, because there's not enough of us who are highly specialized and trained in this treatment to serve the need, sadly. So what we do is support them waiting well. And you know, I think that, and we collect data. Like, I think this is super exciting. Like, we get to, you know, I think the next 10 years, I'm very eager. I think between McMain's research and, you know, Linehan's component analysis, like, I just think we're going to see a lot more studies in this area. And, you know, slight modifications and changes, doing it this way, that way, you know, to really understand how we can get the biggest bang for the buck.
Okay. All right. Well, thank you for stepping just slightly beyond your interpretation. I think that's great. Thanks, Linda. And let me just say that there were several questions asking about the upcoming skills training thing and should I do that or the DBT thing. So for folks who might be interested in that, let me just say I hope I'm going to turn my camera on here so you can see me also. So the way that we've been thinking about all this just in terms of the skills stuff is really focusing on deliberate practice, this idea that there's a lot of data about expertise that says that all of us tend to plateau. And so there are two things that we're doing right now. Oh, I did put this in because it's my favorite, which is all of us tend to end up getting beyond the suck threshold here, but onto the amateur, which is now that I can do it, I just do it the same old way I've always done it. And so what we've got are a couple of learning formats for DBT therapists that help get you up more into this. I'll keep pushing myself. There's always some way to do it better. Kicking ass threshold. So I love this slide from Kathy Sierra. And so here are two, if you guys are interested. There is, if you're more interested in the individual therapy comprehensive role, then probably it's a good bet to, if you were interested, join us for the DBT learning community. This is for experienced therapists. We're really focusing on fidelity, but then also lack of progress cases, and then stage 2, actually 1.5 to 2, because it's when they've got the behavior under control, but they still are suffering. And what do you do about that? So that's what this community is about. And then Linda and I are doing a cool new format this year called DBT Skills. And it's really meant to help you improve your skills, get the new ones that are in the treatment manual that Linehan just put out, but also strengthen some of the hard-to-teach oldies but goodies. And the format for that goes from a module that's kind of like a kickoff for each of the modules, so a little bit on mindfulness each time, but then a focus on emotion regulation, interpersonal effectiveness, stress tolerance. And then a period of time where we're all practicing and sharing cool, fun stuff. We've got 2 co-teachers joining us who are adolescent trainers, some of the best we know. And so they have all these great ideas about how to do it in a fun way. And then we end each of these little modules with a show and tell where, you know, we kind of show our best renditions of stuff. So it's pretty fun. So if you guys are interested, of course, we'd love to have you join us either in the learning community that's more focused on individual and kind of comprehensive DBT, or the one that's specific to skills. All right, let me just check the chat here. A few thank yous coming in. And if you want to, we'll leave this chat area open so that you guys can continue to ask questions, and we'll send out a little follow-up that has Linda's updated slides. And there were a couple of further articles and whatnot that sound like we should gather up. We're happy to do that. But if you have any other questions that you were burning but you weren't quite quick enough to type them in. We'll do our best to get you some answers to those. Linda, thank you. That was quite the whirlwind.
Hopefully it was all right, everyone.
I thought, yeah. I mean, people, if you want to give some feedback here about it being useful, you know, what you got out of it, that's always helpful. But yeah, Linda, I don't think there's been another place where there's been that kind of pulling it together for the data, so it's super helpful. Really
Great, thank you. Appreciate it.
All right.
Thanks.
Okay, you guys, I'm going to leave the chat area open for further questions, but otherwise we'll sign off on the audio portion of the call now. And say thanks all.
Thank you. Thanks,
okay.
Kelly.
Bye-bye.
Bye-bye.
Bye, Linda.